A 60-year-old lady, housewife by occupation, residing at Sunabhatti, came with chief complaints of generalized weakness since 6 months, lump over right lower abdomen since 3, intermittent pain in lower abdomen since 1 month. Yes, ma'am.
Continue. No, nothing. Continue.
She was apparently all right 6 months back when she noticed easy fatigability in strenuous activities, but was able to perform her daily household activities, which gradually progressed to limitations in doing the routine activities currently. There was history of loss of appetite for the same duration, decreasing in her diet up to half the amount of the initial, and unintentional weight loss of 7 kgs in the last 6 months. She was 57 kgs and now she's 50 kgs. Over the right lower abdomen.
Your voice is breaking.
Back while bathing, which has increased gradually to the current size of roughly to the base of her history of erection.
Kshitija, your voice is breaking, the echoing. Is it because you are using iPad rather than the laptop? You are using iPad or is there a noise going on around you? Yeah, because right now there's a lot of echoing.
No, there's a lot of voice is breaking.
Now is the voice better?
Yeah.
Yes.
Continue.
If I was not.
Yeah, continue.
Okay.
No, continue from here.
She has history of intermittent right lower abdominal pain for the last 1 month, which was insidious in onset, dull aching in nature, non-radiating. There was no aggravating factor. It was relieved with oral analgesics and it was not related to food intake, defecation, or micturition. There is no history of hematochezia melina. There are no signs and symptoms suggestive of obstruction, breathlessness, hemoptysis, or chest pain, back pain, jaundice, or headache. There is no history of fever, vomiting, dysuria.
Just wait. You said signs and symptoms of obstruction. Will the patient tell you the sign?
There is no history suggestive of any signs and symptoms of obstruction, like bilious vomiting, inability to.
But signs are one which you elicit. There can't be any history of signs.
Yes, sir.
Huh? And you have already said that there is no alteration of the bowel habits or their difficulty in maturation. Okay? So which are the symptoms of obstruction you are talking about?
Bilious vomiting.
So that you could have
abdominal
told
distension.
that you should have. Okay. So then say that there is no history of abdominal distension, obstipation, constipation, or vomiting, rather than talking about signs symptoms of obstruction. Okay?
Yes, sir.
Yeah.
There is no history of fever, vomiting, dysuria, hematuria, and there were no similar complaints in past.
You said
she has history of
hemoptysis.
tubectomy done 38.
Just wait back. Go back.
Yes.
Go back. You said breathlessness, hemoptysis, or chest pain, or back pain, and with that you have clubbed the jaundice or headache. What are you going to convey in a patient?
Sir, in a so she has her age, the signs and symptoms all point towards malignancy. So we need to rule out if there are any mets. That's why breathlessness, hemoptysis, chest pain, back pain for bony mets, and headache and jaundice for any liver or brain mets.
I don't know whether others will agree. Anybody else? Supay join or Priya? What do you think? Hello? Is Priya there?
Yes, sir.
Yeah. You think that what she is talking about, breathlessness, hemoptysis, chest pain, back pain, jaundice in a patient, and headache.
This is, sir, in this particular case, not specifically important.
Yeah, it's not
But-
warranted.
Yeah, so this is actually good if you're taking an MBBS case, but
Yeah.
at MS level, just give specific negative history.
Yes, ma'am.
You say there are
What
no
are you trying to
associations.
rule out by this sentence? Like, what are you ruling out?
Metastasis. Any systemic metastasis.
Okay, but I think if you prove, like, give negative history of this thing CA, then this is not required. मतलब, ठीक है?
Okay, ma'am. Yes, ma'am.
है ना? She has no history of hematochezia melina. Weight loss she has?
Yeah,
Yes, ma'am. Significant weight
अच्छा.
loss.
Okay, but that can be because of TB also. ठीक है, so
Yes, ma'am.
such a
She did not
far-fetched
discharge
history
work.
for See, before proving no history of metastasis, no symptoms of metastasis, better to prove no symptoms of CA. I think need not go to complications of CA ka negative history is what I feel.
Yes.
No? Okay.
Now, vomiting is a part of your history because patients come with the pain abdomen. Now, you are again repeating here, no history of vomiting. Okay. The lump were noticed, and
Yes,
there is
sir.
no history of fever. Fever will go there. You already said there are no urinary symptoms, so why dysuria and hematuria now? It's already covered. So, see, basically, you are wasting your time on repetition of the same thing. Okay.
Sir, based on the history, it was just right-sided pain to rule out if there is any urinary component.
See, you
That's
go to
why
you go to your previous slide.
Yes, sir.
You written no related to food intake, defecation, or micturition. That pain, right? The leaking.
Yes, sir.
So, if it's not related to act of micturition, where is the question of other symptoms?
Yes, sir.
Okay. Try to be precise and to the point and convey the message in a lesser number of sentences. Okay. Yeah, go ahead.
Yes, sir.
Go ahead. Go for the next slide.
Yes.
No.
She consumes a mixed diet. There is reduced appetite, bowel, bladder, and sleep have been unaltered, and she denies any addictions.
Okay. Reduced appetite, you already talked about.
There is no. Yes, sir.
It should not be a repetition. Okay. You said past history something.
Sir, for the
Slide before this.
sir, for the sake of completion, should I not add or yes?
No, you go to that past
Sir,
history
I had a
slide.
question.
Yeah, please.
Yes, sir.
History of tubectomy 38 years ago.
There is history.
No
There is no
more
known comorbidities. There is no history of
tuberculosis or contact with person suffering from tuberculosis. Very good. Okay. Yes, somebody was asking something. What was that?
Sir, I had a question. So here in the personal history, we always mention bowel, bladder, appetite as like a pro forma or like to cover everything. So if we've already mentioned regarding.
Yeah, if you already mentioned something, you don't have to repeat. That's what is being said. That is not MBBS. It is MS level. You have to synthesize and then present. Okay.
Yes.
So what you already covered, you don't have to come back again to same thing.
Yes, sir.
Yeah.
Sorry, sir.
Yeah. Go ahead.
There is no similar illness in family, no history of cancer in family.
So no history
Menstrual
of
history.
cancer and tuberculosis in the family. These two things are important. Okay.
Sir, if in the past history, if we've already mentioned no history of tuberculosis or contact, then should we again mention here in family?
See, contact can be outside contact also, no? And the family history is different.
Yes, yes, yes. In menstrual history, she is postmenopausal. Menopause achieved at 50 years of age. Menarche at 14 years of age. Cycles were regular. P2, L2 status. Both full-term normal vaginal deliveries. Both male, 42 and 40 years old.
Okay.
The summary of history. A 60-year-old lady presented with complaints of generalized weakness for 6 months, lump over right lower side of abdomen since 3 months, associated with loss of appetite and significant unintentional weight loss with dull aching, intermittent pain in the right lower abdomen for the last 1 month with no comorbidities and no fever.
Now, see, with no comorbidities or fever is not as important. Fever is okay. With no associated GI symptoms. See, you have talked about hematochezia.
Yes.
Okay. You talked about melena. You talked about the patient didn't have
Yes, sir.
obstipation, vomiting. Okay. So, no associated GI symptoms.
Yes.
Comorbidities are not that
patient
important.
Symptoms. Okay.
Yeah.
Did the
Yes.
patient complain of lump in abdomen? Or was that your clinical finding?
Yes, ma'am. No. She noticed it while she was having a bath about a month ago.
Lump in abdomen patient noticing even if it's CA or maybe appendicular lump or maybe TB ka mass, it's less likely na patient notice themselves. It's not like a lump in the breast.
Yeah.
Less likely that patient will tell until and unless the patient is very thin. That also I'm doubtful that patient will themselves notice that.
So, yes. It's a good point. Is it the
I have
lump
a
she
picture,
noticed?
ma'am.
No, is it that she noticed the lump or she noticed the
Fullness. You can say fullness or
or
heaviness.
abdominal
Yeah.
distension in that area?
So you can say abdominal distension in lower half or ऐसा, है ना?
Okay.
और right side, lower right side. Lump you cannot say.
Yes, sir.
Patient ये नहीं बोलेगा कि मेरे को वहाँ पे गांठ है. Patient will say कि ठीक है सूजन आई है या distension है. Usually.
Yes, ma'am.
No, so you can mention fullness or distension.
Yeah.
Yes, ma'am.
We can go to examination and feel.
Yeah. No.
On general examination, the examination was
No,
done in a well-lit room
you
on
put up a
exposure from
slide.
nipple to mid-thigh.
Wait. You put up a slide of based on the history or differential diagnosis. Go back to that slide.
Yes.
Yeah. So how do you support in the history, except that you are saying the patient complains of the lump?
So, sir, she had generalized weakness since past 6 months, and along with it, she had easy fatigability, as she mentioned, and there was she felt a lump, like she said that she had feeling of a lump, and she had significant weight loss. In a 60-year-old female, we need to rule out the first primary diagnosis, which can be a malignancy. And due to the endemicity of tuberculosis, we should always keep that in mind that it can be alimentary tract tuberculosis.
Yeah.
So these were my two.
The correction will be, as Priya pointed out, right left fossa lump, unlikely that the patient will complain of. Okay. The fullness can be there. The lump you will detect.
Yes, sir.
So you can say based on the history, I suspect the patient might be having abdominal malignancy.
Yes, sir.
Or tuberculosis, and most probably it is localized into the right leg fossa because she has got pain in the right leg fossa or right lower abdomen.
Yes, sir.
Okay. So
yes,
that is acceptable because that you can support with loss of weight, loss of appetite, and there's a pain in the and there's some fullness in the right lower abdomen. Okay, so you can say that there is some pathology in the right lower abdomen. Most probably, I will suspect it could be malignancy or tuberculosis. Okay,
Yes.
go ahead.
Examination. On a general examination, it was done in a well-lit room on exposure from nipple to mid-thigh after taking informed consent in supine position. Patient was conscious, cooperative, oriented to time, place, and person. She was fairly built and fair in nutrition. The BMI was 20. There was mild pallor present, no icterus, cyanosis, clubbing, edema, and generalized lymphadenopathy.
Wait.
Yes.
Go back to slide. Go back to slide, previous slide. You said fair nutrition. No, that general physical
Yes, sir.
examination. General
Yes,
examination,
yes,
you've gone back to, you are showing, yes. You are saying fair built. Built is okay. Fair nutrition with a BMI of
Yes.
20. And you said that patient has history of significant weight loss.
Yes, sir.
So nutrition will be fair?
How do you assess nutrition? Because your question will go there now. Now we are discussing pediatrics. What are the signs? Like, how do you say patient has a fair nutrition or not? Is it just based on BMI?
Mid upper arm circumference.
So did you
then,
take all that?
Skin
Nahi na?
fold thickness.
So did you take वही तो skin turgor, fold thickness, all those things? Did you check that?
Nahi, ma'am. Based off of
Oh,
BMI,
it's okay.
I had mentioned.
Well, this is what sir is trying to say.
Yes.
Yeah, because you will be taken on the, because when you say significant weight loss and you say fair nutrition, they don't go hand in hand.
Yes.
So your assessment should be proper. Okay.
Yes.
Because you will be asked immediately how do you assess the nutrition, and then have you taken the mid-arm circumference? Okay.
Yes, sir.
That will be asked to you. Okay. So be careful writing such things.
Yes, sir.
Yeah. Go next.
Yes. The pulse rate was 84 beats per minute, regular rhythm, good volume, no vessel wall thickening. Respiratory rate was 18 per minute. Blood pressure was 130 over 80 millimeters of mercury, measured in right arm in supine position, and she was afebrile.
Again, here, why do you want to mention no vessel wall thickening? Is it significant to your differential diagnosis? If she has vessel wall thickening, does your diagnosis change? हाँ तो मतलब मेडिसिन का एग्जाम नहीं है ना, इट्स ओके. इफ अगर यही केस अगर पेरिफेरल आर्टीरियल डिजीज का रहेगा, लोअर लिम्ब का, देन यू चेक अदर पेरिफेरल पल्सेशंस आल्सो. उसमें तो टेम्पोरल भी चेक करने का, कैरोटिड भी चेक करने का है ना. रेगुलर रिदम, गुड वॉल्यूम इज गुड इनफ.
Yes.
डोंट हैव टू मेंशन नो वेसल वॉल थिकनिंग. ठीक है.
Yes, ma'am.
Yeah.
This was like a rough marking done by the marker, and I have taken pictures of her abdomen. So
Yeah.
on inspection, abdomen is flat in shape. On
Just
inspection,
go to your
abdomen
previous
is flat in
slide.
shape.
Son, don't read out your slide. Go to your previous slide. हाँ, now you describe inspection. Don't go to your
Yeah.
slide. Don't read
Yeah.
out everything. इसको देखो और बोलो कि क्या क्या दिख रहा है.
Abdomen is flat in shape. Umbilicus is centrally placed and inverted. There are no dilated veins. Striae albicans is present. There is a scar of tubectomy done midline in the lower abdomen. All quadrants were moving equally with respiration. There was no visible peristalsis or pulsation on examination, and there was full abdomen, and no swelling or lump was visible, and the hernial orifices were
What is the significance of all
on
quadrants
hello.
moving equally with respiration?
So if it was some retroperitoneal lump or vague mass which was seen or fullness which was seen, then it would not have moved with the respiration.
Oh, you said, what is the question is what? You said all full four
All
quadrants,
four
abdominal
quadrants
wall.
move equally with respiration.
That means abdominal wall moves equally with respiration.
So
isn't
इसमें
it?
if there is a lump there, that quadrant should not move equal as compared to the other, no? So basically what I'm trying to say कि अपने आप मतलब don't give, कैसे बोलूँ मैं, you are inviting trouble ऐसा.
Yes, ma'am. If the so if the lump is present, then that quadrant will not move with respiration.
तो यहाँ पे तो lump है ना.
But if the lump is intra-abdominal, then the lump moves with respiration.
You are confusing bit. You are confusing. Lump may move with respiration. What you are talking on inspection is the abdominal wall movement. Okay. So abdominal wall movement restriction will be if there is inflammatory process inside. Okay. That's why there will be restriction to
Yes,
abdominal
sir.
wall, right? Because there is irritation, the moment the
Yes,
patient
sir.
takes the deep breath and the abdominal wall moves in, there will be irritation of the peritoneum. So there will be restriction of movement in that particular area. Or there is a mass in the abdomen in that area, which is preventing the abdomen going in. Okay. Then you will find that in a
Yes,
particular
sir.
area, the abdominal wall is not moving with freely. Okay. As compared to the other quadrants. That's what Dr. Priya was trying to tell you. So it's not movement of the lump with respiration. We are not talking about, because there is no visible lump. Priya, do you think that there is a visible lump here?
Maybe
I see.
after palpation you can
Yeah.
say there's just mild fullness, but I don't think it's fullness is still there.
Actually, fullness is more in the left iliac fossa and the right leg fossa, means both sides, infraumbilical area going towards the pelvis.
That's why I tried to take a photo perpendicular to show that there's a bit of bulge kind of thing.
Yeah.
On the right one, on the right picture.
Yeah, on the right picture. You should have taken the picture from the left side also, so that you can compare whether both sides there is a bulge or only one side. Because the supine picture, which is frontal
Actually, I
view.
don't have a picture of the other side.
Yeah.
There was a wall that side. I could know.
Okay. Yeah, because supine picture, what you are seeing, it's the bulge is seen both sides. Frontal picture.
Yes, sir.
Okay, go ahead.
Okay, go ahead.
So I have one question. When we mention for any intra-abdominal mass that the lump moves with respiration, and when we say that the abdomen is like all quadrants of the abdomen move equally with the respiration, then there are like for when we mention that the lump is moving with respiration, by that we mean to tell the examiner that the lump is more like abdominal.
So there are two things.
So when we, yes, sir.
So on inspection, you don't talk about the lump moving with respiration. All right, it is a palpatory finding. Because on inspection, you may get the wrong impression because the abdominal wall is moving. You feel that the lump is moving. That's one. So there is fallacy. Number two, the lump should have been in the upper abdomen. Okay, not in the lower quadrants. If it is in lower quadrant, it is not going to move with respiration. All right, because it is not in contact with the diaphragm, directly or indirectly. So it has to be in the upper abdomen lump. So here the lump is not in the upper abdomen, so no question of you talking about the movement with respiration on inspection at least. All right, and even same thing applies to the palpation. If you are seeing a upper abdominal lump and where there is visible lump, it's like a liver enlarged. Okay, and the abdominal wall person is very thin walled, and then you are seeing the lump, you are seeing inspection, there's a fullness in that area. Okay, and which is moving with respiration. So some people will accept it. But usually the movement with respiration is a confirmatory finding is with the palpation. Okay,
Yes.
not with the inspection.
And as sir said, this is mostly said for renal masses or splenomegaly because they are in close contact with the diaphragm. Or in case of
Diaphragm,
kidneys, it's
yes.
a retroperitoneal organ. Okay. So for this patient, you don't have
Yes,
to
ma'am.
say it moves with respiration or not.
Yes, ma'am.
Okay.
Go ahead, go
On
ahead.
palpation, there is no local rise in temperature. Abdomen is soft and non-tender. All inspiratory findings were confirmed. The scar of tubectomy is palpated in midline, 15 centimeter below the umbilicus and 7 centimeter above the pubic tubercle. There an intra-abdominal lump of roughly 5 palpable in the right iliac fossa, extending to the right lumbar region, oval in shape with more length craniocaudally than horizontally, hard in consistency, defined and irregular margins and irregular surface. There is no fixity to the skin. No other organomegaly. The hernial orifices were normal. On leg raising, the lump becomes less prominent. Should I go ahead?
No, I always have this problem of no local rise in temperature in cases of abdominal lump.
Yeah.
Your differential diagnosis is ileocecal TB, ileocecal whatever malignancy, or even if an appendicular abscess or a lump. इन तीनों में से किस में होता है local rise of temperature on the abdomen? What are you trying to rule out with this local rise? Which condition will you find local rise in temperature over the abdomen?
Psoas.
Psoas abscess.
Psoas abscess is cold abscess.
So subcutaneous मतलब abdominal wall abscess.
Yes, ma'am.
Is that even your differential diagnosis?
No.
Then why do you have to say no local rise of temperature? पूरा का पूरा दास उठा के छाप नहीं देना है. ठीक है? If it's not relevant, don't write. No, जबरदस्ती थोड़ी है सब कुछ लिखने का. It has to be relevant here.
See,
है ना?
for Kshitija and everybody, what Dr. Priya is trying to tell you that when there is a local rise in temperature in the abdominal wall, that means the inflammatory process is either in the parietes, that is abdominal wall itself, or it is an intra-abdominal inflammatory pathology which has involved the abdominal wall. Okay. So in that, the signs of inflammatory reaction, that is the redness, will be seen first, isn't it?
Yes, sir.
Then the local rise in temperature comes into picture. Okay.
Yes.
Yeah. Now you are saying that intra-abdominal lump, as you said that it is because on head raising or leg raising, what did you do?
Leg raising, sir.
Leg raising, it becomes less prominent, is it?
Yes.
Okay. And you said it is 5 by 4 centimeter. Yes?
Yes.
And then right left fossa extending to the right lumbar region. 5 by 4 centimeter, did you see how much is a 5 by 4 centimeter? If you see on your finger, how many phalanx
Yes,
it will
sir.
cover? 5 centimeter. If you take your index finger.
The length of the index finger, sir. About
Length,
little bit.
it depends on your length of with your hand and size. Okay. All right. So that 5 centimeter, you think right leg fossa. Now, what are the boundaries of right leg fossa? Where is the upper limit of right leg fossa?
Anterior superior iliac spine.
Hmm?
Sir, the ischial, the line passing through the bilateral ischial anterior superior iliac spines.
Ischial कहाँ आएगा? Ischial तो bottom पे होता है बेटा.
Sorry, iliac crest, sir.
What is it called? Iliac crest. Iliac crest is extending from anterior iliac spine to the back
Post-
side. फिर
Yes.
which plane it is?
L2.
No, L2 नहीं. You are right in relation to the iliac crest, but which part of the iliac crest it goes? Anybody? Janil? Is he here? Janil is
Sir,
here?
I don't know, sir.
You don't know.
Yes, sir.
You don't know the planes, how to divide the abdomen in 9 quadrants?
Yes, that
So I'm asking, where is the right left fossa upper limit?
transtubercular plane, sir. So ischial
Transtubercular
tuberosity.
plane. So why did you say I don't know?
Yes, sir.
So what is that tubercle? Where it is?
Iliac tubercles.
Iliac tubercle. Okay.
Yes, sir.
It's not anti-superior spine, right? So that is transtubercular plane. So right left fossa ends the upper limit there, isn't it?
Yes, sir.
Okay.
Yes.
And then the lumbar area starts. So that means your lump is not exactly in the right leg fossa, it is at the junction of the right leg fossa and the lumbar area.
By extending, I meant that it's in between that
Okay.
part.
At the junction, fine. Okay. And what else you have not said? Oh no, palpation. What is
Yes.
it? Did you talk about the mobility? On inspection, you were talking about the mobility. Now, when palpation, have you looked for the mobility?
Sir, it was not moving, sir.
So have you mentioned here? I don't see any difference there. In your finding, you have not written that the lump is not mobile. And physically, you can't move in any direction. Or is it mobile?
Sorry, sir.
Is it mobile? It is not
No,
mobile. Not mobile. It's fixed.
not moving.
Okay. Good.
On percussion,
Hmm.
the percussion over the lump is dull. There is no evidence of free fluid. Liver span is 11 centimeters and normal tympanic note in the rest of the abdomen. On auscultation, the bowel sounds were normal. On digital rectal examination, externally there were no skin tag, mass per annum. The tone is normal. Internally, there was no growth, mass or deposits felt. Mucosa was free, and finger was stained with fecal staining.
Yeah. Okay.
Instead of
Before
fecal
doing-
stain, just say normal colored stool staining present, because the color of feces is important, no? कुछ मरीना नहीं है, कुछ bleeding नहीं है.
Yes.
So normal colored stool staining present.
Yes, ma'am.
And ideally, do you percuss over the lump? मेरे को नहीं पता, दास बोलता है क्या ऐसे कि lump को specifically percuss करके देखने का? But I don't remember, इसलिए I'm asking. Hello.
It was 5 by 4 centimeter. It
अरे,
was 5 by 4 centimeter.
मैं क्या बोल रही हूँ, परकशन ओवर द लंप, मतलब ऐसे रेकमेंडेड है क्या कि लंप को अलग से परकस करके देखना है? आई एम जस्ट ट्राइंग टू आस्क दैट बिकॉज आई डोंट रिमेम्बर एवर डूइंग इट आल्सो. एक बार दास चेक करो. आई डोंट थिंक सो यू आर सपोज टू लाइक स्पेसिफिकली परकस लंप्स अलग से.
No, lump percussion can be done. See,
Can be
because sometimes if it is a distended bowel loop, okay, which they
Okay,
are
sir.
feeling as a lump, it could be tympanitic. So
Okay, sir.
percussion over the lump is fine.
Okay.
Dull. Okay. No evidence of free
Okay.
fluid. Yes. And there is no organomegaly. Okay, fine. Anything in particular you will look for, which you didn't mention even general physical examination?
Lymph nodes.
No. Yes, lymph
I
node.
had
Which lymph
mentioned
node?
in general physical.
Acha. You mentioned about the left
I had
supraclavicular lymph
mentioned.
node.
See, generalized lymphadenopathy is
So
different.
So, hello.
Left supraclavicular lymphadenopathy, I had not mentioned.
So you have to
Where
mention as a
should I
part
mention
of the
it?
abdominal examination. As a part of the abdominal examination. Okay, there is no left supraclavicular lymph node is not palpable. And did you examine the patient from behind?
Sir, should I mention it?
Yeah.
Yes, sir.
What?
Spine was normal. Sir, I wanted to ask regarding the left supraclavicular lymph, if there is any lymph node enlargement, where should we mention it? In the inspection, like, or in the palpation, or if we find it during the palpation, then during palpation.
After auscultation, after digital rectal examination, you just mention that the left supraclavicular lymph nodes not palpable. एक sentence बोलना है.
Yeah, absolutely.
And that does not get automatically included in your generalized lymphadenopathy. ठीक है? This is a specific negative history since you are like proposing it as a ileocecal malignancy.
Malignancy.
So specifically you have to give specific history because that rules out indirectly matlab metastasis. Does not rule out, but yeah.
Yes, ma'am.
And did you mention about the renal angles? Because you said the lump is going into a lumbar area.
No, sir. Sorry.
The missed finding, no? You have to talk about that.
Yes. Yes, sir.
So these two important findings should be mentioned apart from the spine.
Yes.
Okay.
Yes, sir.
Go ahead. Go ahead.
Yes. Cardiovascular system S1 S2 present, no murmurs. Respiratory system bilateral air entry equal, no added sounds. Central nervous system higher mental functions intact, no deficit.
Okay.
Can this be a
My
right
case
renal
summary is
malignancy?
unlikely, ma'am, because there was no urinary symptoms, and
There might not be urinary
if it
symptoms.
was then it would have been more in the lumbar region and less in the right iliac fossa region.
Can be a lower pole mass, which is extending from the lumbar region to like slightly in the iliac fossa.
Then we would have been able to bimanually palpate.
तो वो किया है क्या?
No, ma'am.
तो ये सब पूछेंगे हाँ?
Yes.
Because see, the case you will get ना, that would already have been presented by 2-3 different people. क्योंकि मेरे साथ भी यही हुआ था एग्जाम में, ठीक है? So they are not going to ask you
Yes.
again ileocecal TB and ileocecal lump. Okay, so they'll ask you other things that are possible there.
Yes.
है ना? So you have to be like ready with that. ऐसा नहीं कि पता चल गया कि ये वाला केस है तो just relevant नहीं पूछने वाले हैं. वो वाले quadrant का सब पता होना चाहिए.
So, Kshitija, you said it is
Yes, sir.
intra-abdominal
Yes,
lump.
sir.
Okay. You
Yes,
said it
sir.
is an intra-abdominal lump. All right. Now, intra-abdominal lump can be retroperitoneal or intraperitoneal. So, is it
It can be
retroperitoneal mass?
retroperitoneal.
Is it retroperitoneal or intraperitoneal? How do you find out?
The intra-abdominal
Because you
mass
didn't
is
mention in the examination. You didn't mention that in the examination and in summary also. And here again, you have not talked about the fixity of the lump.
yes. Sir, intra-abdominal lumps would fall forward when the patient is on all fours, and
So that is intraperitoneal.
retroperitoneal.
Intraperitoneal.
Yes, sir.
And retroperitoneal?
These things are usually not done, na? So you don't have to say. Because I'm sure exam mein you won't ask the patient to go on all fours and see if the lump is falling or not. है ना? So एक जो velocity तुमने बोला bimanual palpation, you to say that. है ना?
Yes, ma'am.
Can it be a right ovarian mass? Huge 10 centimeter or maybe 15 centimeter mass.
Ma'am, it can be, but the
Right?
lower margins.
हाँ हाँ तो say ना तो I'm just asking you questions जैसे एग्जाम में पूछे जाएंगे. So
Yes.
tell the lower margin is palpable. So that is why it
Ah,
cannot
yes,
be
ma'am. So the unlikely.
unlikely.
Yes.
So tell no.
Yes.
All right. What is your differential diagnosis? Come to ready. Come to
My
DD.
provisional diagnosis. This is a malignant mass in the right iliac fossa, probably carcinoma cecum without any distant metastasis.
Why can it not be ileocecal TB?
There was no history suggestive of any chronic inflammation, no history of low rise of temperature. So that's why I ruled out ileocecal TB.
Why it cannot be a lymph nodal? What is your other differential diagnosis? You say that malignant mass in the right left fossa, most probably arising from the cecum. All right. That's what your first diagnosis. What is the differential diagnosis? Apart from tuberculosis, which Priya talked about.
Any chronic inflammatory condition like
Which, like what? See, you don't be vague.
cecal
What is
diverticulitis.
once you say tuberculosis is the chronic inflammatory process. Which other you are talking about?
Yes.
Which other chronic inflammatory process you are talking about which form a lump in the right leg fossa?
Any diverticulitis which is there, cecal diverticulitis.
Diverticulitis. When the diverticulitis forms a lump, what the complication has happened here? Which complication has happened
Abscess
from the
and then
abscess formation, right?
yes.
In that case,
Yes.
you said there is no history of fever. Okay, the
Yes.
lump is not tender, and the lump will be
Yes.
hard.
Hard, sir. Yes.
Yeah, lump will be hard. Here you said lump is hard, right? With irregular surface.
Here the
Patient
lump
का
is hard.
history का duration क्या है? Duration of
6
presentation?
months.
तो 6
6
months तक diverticulitis
Since
रहेगा. That will be an acute presentation or a early presentation, no? Pain, fever, lump. Or either patient will
Yes.
give history of all those things and admission may be conservatively managed, ऐसा कुछ. 6 महीने का history less likely ना diverticulitis or diverticular lump without any prior history of
Yes, ma'am.
any medical management.
See, Remember one thing, you have right in the beginning on the basis of history, you said you are suspecting either a malignancy or a tuberculosis. Okay, because of the presence of
Yes, sir.
constitutional symptom of a significant loss of appetite and
Weight loss.
right? And now you
Yes,
detect
sir.
a lump in the right leg fossa. That's why, which is hard, fixed, irregular, right? Which you think it could be
Yes.
cecal mass. So what is the other mass which will be palpable there, which will be fixed, nodular, hard, and could be malignant?
Lymph nodal mass.
Huh? Yes, lymph nodal mass.
Lymph nodal mass.
So,
Yes.
so why don't you say that? Now, because this patient has
lymph
no
nodal
GI
mass.
symptom, you said the patient is not having any GI symptoms, right? No alteration of bowel habits, no vomiting, no distension, right? Isn't it?
Yes.
So there are no bowel
Yes,
symptoms.
sir. No, sir.
Now, carcinoma cecum, what is the common presentation?
Melena, fatigability,
Bleeding.
drop in hemoglobin.
Yeah, apart from general symptoms, specific is the bleeding, right?
Bleeding,
Carcinoma
yes.
cecum doesn't give rise
Yes.
to obstruction normally, unless it is at the
Yes.
it is
It's
at the
very
IC junction, where it can block the IC junction. Okay. In that case, it can present with the bowel obstruction. So here there is no bowel obstruction, and
Yes.
also there is no histoiomelena.
yes.
Sir, I still want to know, can we clinically differentiate between IC, ileocecal tuberculosis and malignancy, cecal or ascending colon malignancy, clinically? Just on the basis of no evening rise of temperature, I don't think so we can rule out.
So
We'll need to investigate.
Then you tell, no, my main two differential diagnoses are this, and I would like to investigate further to जो भी prove या disprove. Then we'll ask you कि ठीक है, next क्या करोगे?
So IC tuberculosis mass, hyperplastic ileocecal tuberculosis mass is mobile. Okay.
Yes.
Well, physically you can move. There's some mobility will be there. It's not freely mobile like ovarian cyst, but it will have some mobility. So,
Yes. sir.
so because it is a fixed mass, you will think of the lymph nodal mass or the cecum mass,
Yes.
malignancy infiltrating into retroperitoneum or become fixed. Yeah.
So for the differential of lymph nodal malignancy, can we argue that there would be other lymph nodal enlargement in our examination?
Not
And
necessarily.
here, as we could know,
Not necessarily.
Okay, sir.
Absence of other lymphadenopathy doesn't rule out this to be a lymph nodal mass. Presence can go in favor.
Okay, sir.
Presence can go in
So
favor, but
unless the investigation,
yeah. So you
so
keep a
unless the
differential
investigation
diagnosis.
prove otherwise, we can.
Yeah.
Yes, sir.
See, like Priya was saying that could it be arising from the right ovary? Possible. How can you rule it out?
Sir, because the inferior ends would not be palpable, and here they were palpable.
Why not? Why ovaries, if it enlarges, is palpable, it rises up with the pedicle, it comes in the right leg fossa. Yeah, it is
Sir,
little
in the
higher up
book
for
it
the ovarian
was-
mass. What else? There is one more structure which can be there in that position and will be palpable as a mass. Tell me. Janil, anybody else? Quick thinking and tell me. He said cecum, lymph nodes, ileocecal area, ovarian, what else?
Appendicular lump, sir.
Yeah, lump. Huh?
Appendicular lump.
See, again, you are bringing something which is not fitting into your history and also examination finding, appendicular lump. We agree that it is a mass which is most likely to be malignant, or you say tuberculosis. There are two pathologies. A structure which is retroperitoneal, but not present normally in that area.
Kidney, sir? Or
Yes. Yes. What is it called? What is it
Yes.
called? What is it called?
Horse-shaped kidney.
What is it called? When the kidney is in the not in normal position, the lumbar area, but in the somewhere down.
Ectopic kidney, sir.
Sir, ectopic kidney.
Unascended
kidney,
kidney, yeah. Unascended kidney or ectopic kidney. Yeah. Okay. So there could be tumor arising from the kidney, unascended kidney or ectopic kidney. Okay. What will you
Yes.
do now? So you have a differential diagnosis. What will you do?
Sir, I would like to investigate the patient
Yes.
to
So
find a
which investigation?
definite diagnosis.
Which investigation?
So, colonoscopy.
Colonoscopy. Okay. Normal.
Because it was
Colonoscopy normal. Then
sir, a basic sonography of the
yeah,
abdomen.
the person who is
to-
not identified said CBC. Okay. That is for every patient you have to have a CBC, and which may show the anemia. Okay. See, what is the purpose of investigation here?
to find the organ of origin.
Organ of origin and the pathology if possible. Yes,
Yes, sir.
right. So which investigation is investigation of choice when you are not sure what is the organ of origin and pathology you are thinking between malignancy versus tuberculosis? Yeah. Which investigation will choice?
So, a contrast enhanced CT scan.
Yeah, good. Yeah. So
Yes.
for completion sake, you can say, okay, I will do the screening ultrasound, right? But
Yes.
idea,
Yes, sir.
if you want to get a full diagnosis about this, and also you want to know if it is a malignancy, then you want to know the extent, full extent. Okay. Then a CCT abdomen is the
Yes, sir.
investigation of choice. And
Mhm.
then depending on
Yes.
the findings, you can decide whether you want to do colonoscopy or not. Isn't it?
Yes, sir.
Because if the diagnosis is a lymph nodal mass, will you still do colonoscopy if it is a lymph nodal mass in the right leg fossa?
No, sir.
Why not? It could be metastasis from the cecal malignancy. Primary will be silent. You will do the
Sir, but
colonoscopy.
then the CT scan will show something.
It may not show if it is an early lesion, a small lesion.
Yes, sir. Yes, sir.
So if it is a lymph node mass in the right leg fossa, you will definitely look for. If there are obvious pathology in the surrounding drainage area, then it's okay. But if there is no pathology seen in the drainage area, you will do the colonoscopy to see if there is any mucosal lesion.
Yes.
Yeah. So CCT will be the answer here, right? So
Yes.
suppose the CCT abdomen is done and it shows that there is a lymph nodal mass, no primary seen. Colonoscopy negative. What will you do?
Sir, an image guided biopsy of the lymph nodal mass.
So what do you suspect?
Sir, it can be some occult primary, which has given rise to a lymph nodal mass, or it can be a lymph nodal malignancy, like the lymph
Like
nodal primary.
lymphoma.
Lymphoma,
Okay.
yes.
Say
Yes, sir.
lymphoma. Yeah. Yeah. We have to ask that person who is that red sign. Who is the
Sir, I
person?
asked in the beginning, they could write their name. Can you introduce yourself? Who is that?
Yeah, because she's giving the answer, he or she.
Hmm.
Yeah. In the chat box, she's putting the. Then we can ask after. Yes. So you can do the image guided look at biopsy. Okay. Any other investigation you like to do if it is lymph nodal mass, or even if it is malignancy of the cecum?
So we would like to check for any
Yeah. Check for-
distant metastasis,
Yes.
So-
By doing
a whole body PET CT scan.
very good. Okay. Anything else if it is a cecal malignancy? Any blood investigation?
So to check for the patient's hemoglobin levels, we would do a
Or
complete
if
hemogram
I'm saying
that will let us
cecal malignancy, any blood
tumor
investigation?
markers, sir.
Yes. CEA level.
Tumor marker CEA level. Yes.
Yes. Okay. Why do you do the CA level when you have got a diagnosis already
Uh,
there?
So CA levels will let us prognosticate the patient. So for follow-up, we would like to know whether the CA levels are rising, they're decreasing, or we
Yes.
would like to know the trend of the CA.
Yes. So if it is raised, then after therapy, you will like to see whether it has come down to normal. Okay. If it is not raised,
Yes, sir. Yes, sir.
then it becomes difficult because you cannot use it as for the follow-up. Though some people say that you can still do it because they can be rise in the CA level, new C levels. Okay.
Yes.
All right. So what will you do now? It's a CT scan has showed a fixed lump in the right lung fossa. There's a lump in the right lung fossa, close to the IC junction. Okay. And
Yes, sir.
colonoscopy show the ulcerated lesion there. Biopsy done. It
Yes.
starts as a well
Yes, sir.
differentiated adeno-CA. No other metastasis in
Yes.
anywhere in the body. What will you do?
Yes. So there are no other metastasis anywhere in the body. So we would like to go ahead with the surgery as we have a diagnosis of moderately differentiated adenosine. We would like to go ahead with a hemicolectomy after optimizing the patient. So I would like to know the baseline investigation.
Wait. See, answer is partly right. You have to be very specific. You are doing hemicolectomy for the, see, you should not generate another question from the examiner.
Yes, sir.
What will you do?
Sir, right hemicolectomy.
Right hemicolectomy. Then I will say, what are the types of right hemicolectomy? General, what will you
Sir,
do?
The radical right hemicolectomy.
Yes, radical right hemicolectomy. You're dealing with the cancer, no? Hello?
yes, sir. Yes, sir.
See,
Sorry.
see, you have to be precise. You know, once you diagnosis malignancy, no distant metastasis, the treatment is radical right hemicolectomy.
Radical right hemicolectomy.
Okay. Then the person can ask you what is the extent of nodal clearance, how many nodes you expect, where do you like it, the pedicles and all that, and how will you do it. Okay.
Yes, sir.
So, okay. Priya, anything else?
No, sir.
I think we'll not go into theory of this chemotherapy and all that thing. Will you give, my question can be asked, will you give this patient neoadjuvant chemotherapy?
Yes, sir.
Yes. Okay.
So neoadjuvant chemotherapy will help us in reducing the micro metastasis in downstaging the size of the tumor. And yes, sir.
Okay. And in which case you will decide not to give neoadjuvant chemotherapy?
Sorry, sir.
Hmm?
I'm
Okay.
not sure.
Yeah, this we can discuss a theory topic on Saturday. Okay. In cecal malignancy, role of neoadjuvant and then adjuvant. Adjuvant, yes, you know that. If the histopathology showed the particular stage, then you have to give the adjuvant. Okay. But role of
Yes.
neoadjuvant, where and where. Okay.
Yes.
So, anybody has got any other question to Kshitija? Kshitija, you can stop the this sharing the screen.
Yes. Yes.
Yeah. So anybody has any question or any comment? Janil, Kastub. Okay.
No, sir.
Priya, you want to say anything at the end?
No, sir. I
So,
just
see,
think on investigations, you should first of all focus in proving your diagnosis. Okay. Again, as I said, कि ileocecal TB. तो उसमें directly don't go to CT. इसमें अपना ये blood investigations are also important. है ना?
Yes, sir.
But I think overall, okay.
yeah. Yeah, see, in the exam, when they say, what will you do? So you must always start that you will do the blood investigation to find if there is anemia and all that thing. Okay. And
Yes.
then if he interrupts, okay, that we'll do, but which is specific. So since you are suspecting malignancy, blood investigation, then you will talk about the tumor marker there. Okay.
Yes.
And then I will like to do a diagnostic imaging.
Yes.
Okay. If there would have been bowel symptoms to begin with, large bowel,
Yeah.
then you would have been justified in doing a colonoscopy and then CT scan. Okay.
Yes.
But here you found a lump already there. So that's why the CT
Yes.
is important.
Yes.
Okay. Fine. All right. Can we close down then?
Yes, sir. End for today.
Yeah. Okay. Thank you.
Thank
Thank
you.
you, everybody.
Thank you.